Okay, Chapter 9 is moving and positioning. Movement is very important for everyone. We have to make sure that the patients are being moved and repositioned at least every 2 hours. But if they want you to move them more frequently, you should. But it's extremely important to keep moving. It has a lot of psychological importance as well as a lot of physical importance. And there are a lot of body systems that are affected if you do not move patients. Without freedom, it becomes difficult to move, and moving is just a basic human need. So you can't just let residents sit down or lie down in the bed continuously all day long. You have to keep moving them around, getting them up, getting them down. Even if they're in the wheelchair, they need to stand up at least every 2 hours, weight shift, and get off of their bottom and move around. The goal of movement is to help optimize their mobility, let them do what they can do for themselves. Some of them just need stability, some of them need extra help to transfer. It'll say on their care plan if they're a one-person transfer, a two-person transfer. Even if they're using the lift, you still have to get help, but the resident is also going to help you move and do what they can. If they need to hold on to the side rail, or if they need to hold on to the wheelchair arms, you need to tell them what you want them to do to help you move and reposition them. The human body is designed for continuous movement. If you don't move, you start getting sore and painful. The body is interconnected with different experiences. Even for short-term problems with immobility, it affects all of your bodily systems. So your musculoskeletal system is affected with stiffness or generalized weakness. Your digestive system is affected with a decreased appetite or constipation. Your circulatory and respiratory systems are affected. You get shortness of breath when you're laying down in the bed too long. You get dizzy or orthostatic hypotension when you've been lying still and not moving or not getting up. Your integumentary system, or your skin, starts to get redness and breakdown and skin tears. And then your nervous system starts to deteriorate as you get slowered movement, slowered reflexes, because you're not using anything. Positioning is a term for how you help residents either sit, lie down, or change positions when they're having trouble moving themselves or they forget to change their own positions. So positioning residents correctly helps with skin breakdown, helps to maintain the function of their joints and muscles, and helps to increase their comfort. So even if you have a comatose resident, you still need to move them and reposition them every 2 hours. There are some factors that you have to take into effect when you're positioning people. If they have spinal deformities, you may not want to lay them directly on their back. They may have a little hunchback where it's difficult to lay flat on their back. Also, if they have an area of redness or a skin breakdown, you don't want to lay them on that area or that pressure area because it'll just make it worse because they won't get circulation. If they have casts or splints or any kind of things velcroed to their arm for stability, don't lay them directly on top of that with all of their body weight. If their hands are swollen or their feet are swollen, you want to elevate them above the level of the heart to help with the swelling. If they have IV tubes, make sure they're not laying on their IV tubing. If they have oxygen, make sure it's not getting pulled or kinked or laid on. And then if they've had a recent surgical site, like a hip replacement, or have sutures or staples in, make sure you're not laying them directly, a lot of pressure on that area. When you're moving and positioning, there's a lot of things to think about, your own capabilities and limitations, and what the resident can help you do. So you need to ask the resident how much help they're going to be able to provide. And if they have any special needs or if they have any special equipment that you're going to need to use. Do they have any physical conditions that are going to affect your ability to help move them? Is their skin really fragile where you can't touch them or you'll peel their skin off? Do they have any broken bones? Do they need a walker? Do they need a cane? Do they need a brace? So think of all these things before you go in and start moving them. When you're preparing to move your resident, you have to also get the environment ready. So make sure the lighting in the room is turned on so that everybody can see. Any obstacles are moved out of your way. The bed is at a proper height and the wheels are locked on the bed. So raise the bed to a comfortable working position or lower the bed far enough down where the resident can keep their feet flat on the floor when they're sitting on the side of the bed. Can you maneuver around all of your tubes or all of your equipment? If they have a Foley catheter, you need to make sure you keep it below the level of the bladder, but you have to move the Foley before you move the person so they don't pull out the Foley. We'll talk about that in another chapter with output. Are there any distractions that are going to prevent the resident from hearing your instructions? Is the TV too loud? Is the radio too loud? Are there any family members in the room that you may need to ask to step out while you're helping them get up out of the bed or chair, or to the bathroom, or to the bedside commode? What chair or seating device are they going to need? Do they need a Jerry chair, or do they need a Mary Walker, or a rollator, or just a regular wheelchair? Some people aren't able to sit up in wheelchairs. They have not enough trunk stability to sit up straight in a chair. So they may have a high back chair where you can lean them back a little bit, or they may have this Jerry chair where it's kind of like a recliner on wheels, but we can lay them back a little bit more. You need to know, as far as equipment also, if you're going to need a chair alarm. So you need to put the pad from their chair alarm underneath them. If they are a high risk for fall, they need to have a bed alarm and chair alarm. It'll be on their care plan. It'll be ordered for them, and you need to make sure that equipment works before you set them in that chair alarm or sit on top of that pad for the chair alarm. When you're going to get help, you're always going to make sure that if the resident can't help you so much, you're going to get a second person to come help you. And when you're using your mechanical lift, you always have to have 2 people with a mechanical lift. If the resident is non-weight bearing, you cannot get them out of the bed by themselves. So if they cannot bear their own weight, you have to have a lift to get them up out of the bed. You also have to have 2 people when you're using a draw sheet. So one person's on one side of the bed, the other person's on the other side of the bed, and you're using a draw sheet with 2 people to bring that person up in the bed. The resident can help as well. You need to have them bend their knees, put their feet flat on the bed, and on the count of 3, you're going to push so that you can get them to the top of the bed. This next video is going to show you how to use a draw sheet with 2 people.
When moving some residents, you may need assistance when moving him or her. Never hesitate to ask for assistance when the situation calls for it. Request assistance before you begin. Plan and coordinate the move with your assistant. Perform beginning procedure actions. Ensure that a lift sheet or pad is in place under the resident from the shoulder to knees. Stand on one side of the bed with your assistant standing on the opposite side. Lower the side rails. Lower the head of the bed if it is elevated. Use good body mechanics with feet separated, knees flexed, and 1 foot forward. Now cross the resident's arms over the chest to protect them during the move. To protect the head when moving the resident to the head of the bed, remove the pillow and place it against the headboard. When moving the resident to the side of the bed, determine the direction of the move with your assistant. Roll the lift sheet or pad close to the resident on each side. Grasp the lift sheet or pad at the thighs and shoulders on each side. On signal, lift the resident high enough to clear the bed and move the resident to the desired position. Repeat this process as needed until desired position is reached. Now, replace the pillow and position the resident for comfort and safety. Raise side rail. Now, perform your procedure completion actions.
Okay, so lower the bed back down to the low position after you're done working with it. The draw sheet needs to go from their shoulders to their knees so that it gives you enough stability to be able to lift their trunk up and move them up in the bed. You don't want to drag them across the bed because that shearing is going to cause skin tears. And you just need to, if you can't get them up in one lift, just lift them up, clear the bed, and move them and inch them up to the top several times. Another skill that you're going to need two people is your mechanical lift or your transfer lift. This video that we're going to see is going to be a manual one where you're actually having to pump the lift, but now they have automatic ones that are electronic. So it is the CNA's responsibility to make sure the batteries are getting charged every night for the lifts. And we'll go over how to put the batteries on and where the batteries get charged in the soil utility room. But make sure that you have a battery and a backup battery and that the battery is charged in the automatic lifts. At least 2 people for this procedure. We're going to use the lift syncing. We'll also go over it in class.
The mechanical lift is used when a resident is heavy, unable to assist, unbalanced, paralyzed, or has an amputation or other condition that makes transfer with a belt difficult or impossible. Perform your beginning procedure actions. You will need 1 or more assistants for this procedure. Never attempt to perform the procedure alone. Place the chair at a right angle to the foot of the bed, facing the head. Be sure to lock the brakes on the wheelchair and move the footrests out of the way. Lower the side rail on the side nearest you. Roll the resident on the side. Position the sling under the resident's body so it supports the shoulders, buttocks, and thighs. Straighten the sling. Roll the resident onto the sling and properly position it on the other side. Position the lift over the bed. Spread the legs of the lift to the widest open position to maintain a broad base of support. Attach the suspension straps or chains to the sling. The S-hooks should face away from the resident to prevent injury. Position the resident's arms comfortably inside the sling. Attach the straps or chains to the lift frame. Reassure the resident. Lock the hydraulic mechanism and slowly raise the boom of the lift until the resident is suspended over the bed. Slowly guide the lift away from the bed. Position the lift above the chair. The nursing assistant helping you holds the sling back and helps lower the resident slowly into the chair, keeping the hips back while you slowly release the hydraulics and lower the lift. When lowering the lift, monitor the location of the resident's feet and arms to prevent injury. Unhook the straps or chains and remove the lift. The lift seat remains under the resident. Lower 1 footrest and assist the resident to place foot on the rest. Repeat for the 2nd footrest. Perform your procedure completion actions. Reverse the procedure to return the resident to bed. When raising the resident from the chair, monitor the position of the S-hooks, which sometimes catch under the arms of the chair. Remember, the mechanical lift is a 2-person device, never operated alone. Keeping the lift in good operating condition is essential. If you see an oily substance on the floor near the lift, do not use it until it is checked and repaired. And remember that the lift can be frightening to the resident. Provide reassurance and speak to the resident when moving him or her with the lift. Your attention to detail will help you provide better care to the residents you serve.
Alright, so it's important with those S-hooks that they point away from the body so they don't catch on anything, and make sure they don't catch on the arms of the wheelchair. And then also, if the lifts have a little metal flap on top of the S-hook, those flaps have to be there and intact for you to use the lift. If it's missing one of those little metal flaps or that little clasp, then you need to let maintenance know, and you're not allowed to use that lift. It's per facility policy if you're going to leave the lift seat underneath the person while they're in the chair. Some places, they have a sling for each person. Some places share the slings between different residents. The slings come in different sizes. On the care plan for the resident, it tells you which size sling they are going to need. So if you need to share the sling, then you'll have to Roll the resident from side to side while they're in the wheelchair and get the sling out from underneath them. If the slings are dirty, they go to the laundry to get cleaned, and then they get put back in the clean utility room for storage. So you have to communicate with your residents and with your coworkers whenever you're moving somebody. Give clear directions, make sure everyone knows what to do before you start. When we're doing the moving and positioning with your for your skills, you're going to make sure you have to tell them the cue that you want them to know what to do. Please place your hands on the bed, and on the count of 3, we're going to stand. 1, 2, 3, stand. So you'll see that in the video that we do. Give each resident the task to push up from the bed, grab onto the side rail, make them move whatever they can themselves. If they can pull themselves up in the bed, let them pull themselves up in the bed. So never do for them what they can do for themselves, and always encourage them to help and be a part of the moving process. Positioning in the bed, there are several different positions that you have to know. You're going to use pillows for comfort and support, and in your Mosby's book, there's some pictures, and there's a chapter that shows you the positions that you need to know for the bed. You need to know the reason why the resident would be in this position and what is the appropriate position to be in for certain activities. So your Fowler's position is your semi-sitting position. The head is at least 45 to 90 degrees. Your supine position is when they're laying on their back and the bed is flat. So you're going to put the resident supine to sleep. The prone position requires a doctor's order, but some people like to lie on their abdomen with their head turned to one side. For some people, it's difficult to breathe, so if you're in the prone position, you have to make sure that they, at least for the first 15 minutes, you're with them to make sure that they're not having difficulty breathing. So these are some videos about the Fowler, supine, and prone positions.
Fowler's position is used for feeding residents in bed, for those who have trouble breathing, for comfort when watching television, or while visiting. Lower the head of the bed if it is elevated. Position the resident on his or her back in the center of the bed and in good alignment. Move the resident up in the bed if needed. Elevate the head of the bed to the desired angle. Head of bed is at 45 degrees. Elevate the resident's knees as desired for comfort and to prevent slipping. In the semi-Fowler's position, the head of the bed is raised 30 degrees and the knees are raised 15 degrees. In the low Fowler's position, the head of the bed is raised 20 degrees to 30 degrees. In the high Fowler's position, the head of the bed is raised 90 degrees. Position a pillow under the resident's head and shoulders. Elevate the foot of the bed slightly to prevent sliding. It's important to be aware that this position increases pressure on the hips, buttocks, and coccyx and should not be maintained for prolonged periods. For sleeping, some residents prefer the supine position. Place the resident's bed in the flat position. Now, remove the resident's pillow. Position the resident on his or her back. Move the resident to the center of the bed. If necessary, move him or her up in bed. Replace the pillow under the resident's head and shoulders. Place pillows under the resident's forearms with hands slightly elevated for comfort as needed or desired. Place the resident's hands in a position of use and place hand rolls as needed. Use commercial hand rolls. Avoid using rolled washcloths. The texture of the washcloth may cause the resident to squeeze it, which can make contractures worse. Support the hands with small pillows or rolled towels to support them, if indicated. Place pillows or rolled back blankets against the resident's outer thighs and footboard of the bed. This will help keep the legs straight and the toes pointed upward, which prevents contractures and deformities. Use other positioning methods and commercial devices as indicated to maintain good body alignment. Positioning the resident in good alignment helps maintain proper body functions and is most comfortable. Some residents may be unable to tolerate the prone position. This position may make breathing more difficult for residents with respiratory disorders. Before placing the resident in the prone position, you should clear this request through your supervisor. Request assistance prior to positioning the resident. Lower the bed to the flat position and remove the pillow. With an assistant helping you, use a lift sheet or large pad to turn the resident on the side toward you. Place a small pillow against the abdomen. On signal, have an assistant use a lift sheet to slowly roll the resident onto the abdomen. Turn the head to one side and position on a small pillow or pad for support and comfort. Adjust arms for comfort at the resident's sides or flexed upward. Support wrists for comfort and place hand rolls in the resident's hands. Using a lift sheet, move the resident down in the bed so the toes hang over the edge of the mattress. You may also choose to place a pillow under the lower legs so toes are elevated off the surface of the bed. If this is the first time the resident has used this position, remain in the room for the first 15 minutes. Thereafter, check the resident every 15 minutes to ensure that he or she can tolerate the position. Monitor closely for respiratory distress.
Okay, so the next few positions, one of them is lateral position. The lateral position is going to be side lying. So lateral, you're side lying on one side or the other. The bed is flat. A Sims position is a semi-prone position. It's still side lying on your left side, but you're kind of halfway on your side, halfway on your stomach, halfway prone, so semi-prone. On the left side, the upper leg is sharply flexed so that it's not on the lower leg, and then the arm is behind the person. They kind of look like a running man. And then with a chair position, they have to be able to hold up their upper bodies and head and sit in a chair or a wheelchair. But the lateral position is the one that you will be doing for national testing, and we will work on putting someone on their side with their knee, the top knee is slightly flexed on top of the other. All right. Moving your resident up in the bed, we'll watch the lateral position with me doing the skill for that one. Moving the resident in the bed, the first thing you do is that you need to place the bed in the best position for the move. So raise the bed to a comfortable working position for yourself so you're not bending at your back. If you need to bend, you need to bend at your knees. Put the head of the bed flat and make sure you're putting the pillow at the headboard so that you don't ram them into the headboard. Have the resident bend their knees. If you're using the draw sheet, you're going to slide the resident up on the draw sheet like we already watched, but you have to have at least 2 people to use the draw sheet if the resident is not able to slide themselves.
Moving residents is one of the major responsibilities of the nursing assistant. Use good body mechanics to protect you and the residents from injury. Perform your beginning procedure actions. Lower the head of the bed if it is elevated so the resident is lying flat on his or her back. Remove the pillow and place it against the headboard to protect the head. Instruct the resident to bend her knees and place her feet flat on the mattress. Ask the resident to push down with her feet on signal to help lift the hips. Place your arm with palm side facing up under the resident's shoulders while supporting the neck. Position your other arm with palm side facing up under the resident's thighs while supporting the hips. On signal, lift the resident high enough to clear the bed. Assist the resident to move toward the head of the bed. Repeat this step as necessary until desired position is reached. Replace the pillow and position the resident for comfort and safety. Raise the side rail. Perform your procedure completion actions.
So, if the resident cannot change positions, you need to be moving the residents at least every 2 hours. This applies to your unconscious and your dying residents as well because moving and positioning helps promote comfort. If the resident is having shortness of breath, we already talked about this one, with raising the head of their bed. So pull them up in their bed and get them sitting up and raise the head into Fowler's or high Fowler's position so they can breathe. Range of motion exercises. If your resident is in the bed all of the time, or even if they're not moving around so much, we still need to make sure we're doing exercises. Range of motion. We're going to have a whole chapter on range of motion rehabilitation, but it's done at least once a day, usually with their ADLs or with bathing or with dressing. Have them move all of their joints around so that they are not getting contracted or not getting used and then start shortening and having contractures. There are 6 basic bed positions in your Mosby's book again that you need to make sure that you know. So flat is supine. That's the position for sleeping, spinal cord injuries, patients in cervical traction that need to stay straight, that don't need to be bending or twisting or moving their spine. Those patients are going to be log rolling, so you need 2 people for log rolling, and you're both on the same side of the bed, and you push the person over towards a raised side rail. But the person goes just like a log without bending or twisting. So one of you are at the head, one of you are at the feet and the hips, and you log roll the person onto the side. That's if they have some kind of spinal cord injury or if they're in cervical traction with the weights hanging off the end of their bed. A semi-Fowler's position is when the head of the bed is only raised 30 degrees and the knees are raised about 15 degrees so they're not sliding down in the bed. Semi-Fowler, some people sleep in this position, especially if they have COPD or breathing or respiratory problems. Your Fowler's position is more of a semi-sitting position where the head is raised at least 45 to 60 degrees. Most people like to watch television or read books in this position. Your high Fowler's position is another semi-sitting position where the head has to be up at least 60 to almost 90 degrees, so completely sitting straight up. And for feeding, you have to have your patient in high Fowler's position, but they need to be up at least 70 degrees to feed them. And that's so they don't aspirate on their food. You need a doctor's order to put someone in Trendelenburg. Trendelenburg is when the head of their bed is lowered, but the foot of their bed is raised. Sometimes if people are in shock, or if their blood pressure is really low or hypotensive, we put them in Trendelenburg to get their blood pressure to come back up. Reverse Trendelenburg is the opposite way, kind of like Frankenstein in the bed, where the head of the bed is raised, but the foot is lowered. And honestly, I've never really seen anyone in reverse Trendelenburg in the bed, kind of standing up. So, the lateral position, like I said, this is the one for national testing where you will be putting someone on their side. It doesn't matter which side for lateral position. For Sims position, it's semi-prone and they're laying on their left side. But for lateral, they're just on either side. The head and the neck are on a pillow. There's a pillow between their arm and their chest. There's a pillow under the other arm. There's a pillow behind their back. There's a pillow in between their 2 knees, and the top leg is slightly flexed. The pillow between their legs goes all the way from their knees to their ankles so that both of those pressure points are resting on the pillow.
Come in.
Hello, Mr. Mills. My name is Tanya. I'm going to be your CNA today. It's time to roll you on the side. If the supplies we need for this are going to be our 3 pillows, or wedges, or repositioned devices. I'm going to wash my hands, pull your privacy curtains. And I'm going to make sure that your bed is in a comfortable working position for me. And I'm also going to make sure that you are laying supine in your bed, or the head of your bed is as flat as possible. So you can still breathe. this side, the side that we're going to roll you on. Make sure that your bed wheels are locked, and raise the side rail towards the direction you're going to be rolling. And I'm going to assist you to roll on your side, placing my hand on your shoulder and your hip. On a count of 3, we're going to roll up towards that side rail and hold onto your side rail. 1, 2, 3. Great. Keep position the pillow under your head. Make sure that the arm that you're rolled onto is not being laid on. Put our first pillow under this top arm, supporting the elbow and the wrist. I'm going to place the second pillow behind your back. And the last pillow is going to go between your legs. Your legs are going to be bent with your knees on top, slightly flexed. The pillow needs to go long ways from your knee all the way down to your ankle. Covering you back up for comfort and warmth. Here is your call bell. If you need me, call me. Going to lower your bed back down to the low position. Wash your hands and open your prostate. Thank you.
So we're going to practice doing that, putting patients lateral or on their side. Make sure you're always rolling them towards a raised side rail. And then you can leave that side rail up on the side that they're rolled towards. Complications of bed rest: if we leave patients in the bed and do not move them, do not reposition them, and do not do range of motion, a lot of complications happen with their muscles and joints and skin damage. But a contracture is a lack of joint mobility because of abnormal shortening of the muscle tissues. In the earlier video, it told you to put commercial hand rolls in their hands. So those are also called carrots, but they come from occupational therapy, and they're little rolled up pieces of cotton or cloth that are packed with packing like pillows that help to keep the hands from contracting in on each other. But as those muscles shorten, your body just draws inward. Atrophy is another complication of bed rest, where your muscles will just atrophy or waste away. So if you're not using it, you lose it, it either turns to fat or it just wastes away if you're not using your muscles. And then orthostatic hypotension that we've already talked about is low blood pressure when the patient stands up. So you need to make sure you let them sit up on the side of the bed and dangle for a little bit to get their bearings, to get their blood pressure back before you let them stand up. If they're sitting up and they complain that they are dizzy, then they need to lay back down. They don't need to stand up. Your devices for positioning: if you have a bed board that keeps the mattress from sagging. There's also, if you're doing CPR on someone, you need to put a bed board underneath their chest so that you have a hard surface. You have to be pushing down on their chest, but if you're just bouncing them up and down on a soft mattress, it's not going to give them effective chest compressions for CPR. So sometimes the head of the headboards come off, and you would slide that underneath the person to make the bed not saggy. We also use footboards at the foot of the bed, the board to prevent foot drop from happening. When they're laying in the bed too long, your feet fall forward, or it's called plantar flexion. In order for your feet to move back up into the position that you need for walking, or dorsiflexion, we need to make sure we're keeping their feet in that correct position while they're laying in the bed. Sometimes they're wearing multi-potus boots that help to keep the feet in that position of dorsiflexion. A trochanter roll is just a blanket or a pillow or something at their hips to keep their hips from turning outwards, like frog legs or bow-legged. Used to have these hip abduction wedges. Sometimes after hip surgery, they like to keep their legs immobile, and they would Velcro a little wedge in between their legs. This is what a hand grip looks like, and we'll show you one of those, so to prevent contractures. And then if they have any splints or devices that have Velcro on them, some people have hand splints, some people have knee splints. Amputees have little plastic splints that help to keep their knee in extension. So if you have any kind of Velcro in place, you're going to have to make sure that it's on and appropriate. Ask the resident to help you put it on. Ask them if it's comfortable. Make sure it's not cutting off their circulation. They know how it should be on. You need to ask them to show you how to put it on. If they need a little bit of help, then you can help them put it on. Your traction is after surgery. Some residents have this traction. This is usually just going to happen if you're working in a hospital. They have a pin going through their bones and pulling down off the end of their bed with a weight. These patients are immobilized while these bones are healing. You're not supposed to reposition the resident without the nurse, and again, you're going to get a log roll technique where you're both on the same side of the bed, pushing the person so that the weights don't get disturbed and they don't twist in the wrong direction and re-break that bone or shift the bone from how it's trying to heal. Never change the position of the weights. Always get the nurse if you feel like there's something wrong with the weight on the traction. Transfer considerations. You're using your large muscle groups to support the resident's weight when you're transferring them, but you are not holding the patient up. They need to be able to bear some of their own weight. You're just there to stabilize them, to guide them to where they need to go. If the resident cannot bear their own weight, they need to have a lift or a sling lift to get them up and out of the bed and transferred. When the resident gets out of the bed, be sure to let them dangle their feet for a while, sit on the side of the edge of the bed for a few minutes, help minimize the dizziness, and help them so they're not getting that orthostatic hypertension. If the resident's legs start to give out or extend past your legs, you're supposed to use your legs and feet and knees to block them to get them into the standing position and have them sit back down again. Some more transfer considerations. You always have to make sure that the brakes are locked on the wheelchair and on the bed. So step on the peg to make sure it's pushed down for the wheels that are locked that way, or pull the handle and make sure that the wheelchair wheels are locked. If the resident becomes floppy or passes out, help them to sit down on the bed or lower them to the floor, put them in the supine position, and call the charge nurse. Ask the residents to help again. Hold the armrest, push down on the mattress. Don't let the resident put their arms around your neck. The residents need to put their arms, on your forearms, around your waist, maybe on your shoulders, but don't let them hold around your neck. So this isn't a video about just sitting on the side of the bed and dangling.
Sitting on the side of the bed with the legs over the edge is called dangling. This is the first step to getting out of bed. Sitting on the side of the bed helps residents who have been lying down to balance before getting up. Perform beginning procedure actions. Position the resident close to the side of the bed with his or her feet off the edge of the mattress. Lean toward the resident with your feet separated and 1 foot ahead of the other. Position your arm with palm side up under the resident's arm and around his or her shoulders. Place your other arm with palm side up under the resident's knees. On signal, turn the resident about 1/4 of a turn. Swing the resident's legs over the side of the bed as his or her trunk becomes upright. Instruct and/or assist the resident to support him or herself with their hands against the mattress as well as he or she can. Stay with the resident, providing support as needed, allowing the resident to adjust to the change in position. If the resident begins to feel faint, assist him or her to lie back in bed and notify the nurse. If the resident is to dangle his or her legs over the side of the bed, advise the resident to slowly swing legs back and forth. If the resident is to get out of bed, apply a transfer belt over the resident's clothing and assist him or her into desired position. Check to ensure the resident is wearing shoes or slippers with non-skid soles. If the resident is to return to bed, assist him or her to lie back in bed. When resident is in position, Perform your procedure completion actions.
Okay, so you're going to make sure you're putting their shoes on. They need to get up and they have to have shoes on in order to ambulate or transfer. If they're going for therapy, therapy needs them to have their shoes on. Putting shoes on is part of dressing them and getting them safe. So other things to transfer considerations. If the person is weak on one side, you're supposed to transfer the person so that the strong side moves first. So you're going to place the wheelchair or the chair parallel to their bed on their strong side, and then move that strong side and pivot it first over into the wheelchair. When they sit into the wheelchair, their spine needs to be all the way up against the back of the wheelchair. The back of their hips or the sides of their hips should be touching the back of the chair. Make sure they're far enough back in that seating device to sit up comfortably with support on their spine. Always assist the residents on their weak side when you're walking them down the hall. So if they have a weak side, you're going to be walking slightly behind them on the weak side. If they need to use a cane, they're going to be using the cane in their strong side, and you're walking slightly behind them on their weak side. If the resident is blind, you just allow them to hold onto your arm or hold onto the wall as they're walking down the hallway. Some of them do have little walking sticks that they put out in front of them and move from side to side. If they're just legally blind and they can still see shadows, they can use their walking sticks to know where objects are so they don't run into them. But if you have blind patients or hard of seeing patients, visually impaired patients, you don't move their furniture around because they know where it usually is, and if you put something in their way, they're going to run into it or trip over it. So if you do move their furniture in their room, always put it back where it was. Using your transfer belts, you're never supposed to be pulling up on the resident underneath their arms. You're always going to try to grab them at their waist, grab onto their waistband of their pants if they don't have a transfer belt on or a gait belt on. You're always grabbing the gait belt with an upward grasp. And when you put the gait belts on, they go around their natural waistline, so way down near their umbilical cord or their belly button. Make sure you're grabbing that gait belt with an upward grasp and then just using it to guide or direct the person, but not holding them up with this gait belt. You're definitely not going to be pulling up underneath their arms because there are lots of arteries and nerves and veins underneath their arms. You could also dislocate their shoulders if you're just lifting them up and pulling them from their arms. So avoid all of the lifting from their arms and use your gait belt. To check the fit of your gait belt, make sure you can slide one open flat hand or 4 fingers underneath the belt while you have them sitting down. When you get them up, their weight is going to shift, so the gait belt is going to get looser, but you don't want it so loose that it's just sliding up and down their torso. So when you put it on at their natural waistline, strap it down very tight so you can fit one flat hand underneath it. And then grab it with an upward grasp, and as they stand up, you can put the other hand under there and then help use it to guide them. An exception to the rules with using gait belts, if your resident has a broken bone, broken ribs, abdominal wounds, surgeries in their abdomen, or G-tubes or colostomies, you're not supposed to be using the gait belt. In that case, you're just going to do your best to try to grab at whatever clothing that they have on that's around their waist area and get a good grip on that. But don't put the gait belt on top of anything, any kind of surgical incisions or ostomies or G-tubes, because it's going to injure them. If you have an elderly lady that has hanging breasts, make sure you're not wrapping the gait belt around her breast. You're putting it underneath the breast. Okay. Never place the buckle on the spine. The buckle of the gait belt is always in the front of you. And then you can grasp the gait belt in the back on the spine or on the sides as long as you have an upward grasp. But the buckle always goes in the front. The gait belt is going on top of their clothing, so it's not right up against their skin. It's on top of the clothing with the buckle in front.
If the resident tolerates dangling without difficulty, the next step is to assist him or her out of bed. Evaluate the resident's ability to assist and follow your directions. Perform beginning procedure actions. Position wheelchair next to bed, facing head of bed. Lock wheels and raise footrests. Assist the resident to sit up on the side of the bed with his or her legs dangling. Allow the resident time to adjust to the change in position for a minute before standing. Show the resident a transfer belt and explain its use. Apply the transfer belt over the resident's clothing around the waist. Check the fit by inserting 2 or 3 fingers under the belt. Grasp the transfer belt with an underhand grasp on either side of the buckle. Move the resident forward so his or her feet are close to or touching the floor. Instruct the resident to place his or her hands on your shoulders and lean forward. On your signal, the resident should place his or her feet on the floor. For safety, never allow the resident to put his or her arms around your neck. Place your hands on either side of the transfer belt. On your signal, gradually pull the resident into a standing position, supporting the resident's knees and feet with your knees and feet. Assist the resident to pivot until the backs of his or her legs touch the front of the chair. Move your feet and turn your body instead of twisting. Ask the resident to place his or her hands on the arms of the chair and support him or herself. Bend your knees as you assist the resident to safely lower him or herself into the chair. Lower footrests and place resident's feet on rests. Now you should remove the transfer belt from the resident's waist. Always leave the resident in a position of comfort and safety. Place call signal and needed personal items within his or her reach. Now that the resident is in the chair, take time to ensure that the head and spine are erect. Position the arms comfortably on the armrests and use pillows or pads as needed to support the resident and maintain position. Place a bath blanket over legs for comfort and modesty. Position the hips all the way back in the chair and the legs at 90-degree angles. Make sure residents' feet are placed correctly on footrests to prevent legs from dangling. If footrests are not used for some reason, provide a small stool to support feet. When resident is in position, perform your procedure completion actions.
So again, just make sure that their spine is touching the back of the chair and is supported, and their knees are bent so that their legs are like in a 90-degree angle. They're comfortable in their wheelchair. They're not slouched over, falling out of their wheelchair. At clinical, if we don't put the feet rest back on the patients, they should be able to touch the floor with their feet, and then they move themselves around in their chairs. The wheels on the bed and the wheelchair have to be locked. Move the footrests out of the way before standing a resident up. Make sure the call light is within reach before you leave the resident in the chair. And then remove the gate belt or transfer belt once they are in the chair. So this is a video of how we're going to do it for our checkoffs.
Come in.
Hi, Mr. Nance. My name is Tanya. I'm going to be your CNA today. I'm going to get you up to your wheelchair. The equipment that I'm going to need for this is going to be your wheelchair, a robe to prevent overexposure, your transfer belt or gate belt, and a lap blanket to set in your lap while you're in the chair. First, I'm going to wash my hands, and then pull your privacy curtain. Get the equipment set up and ready. I'm going to place the wheelchair along the side of the bed so that it is facing at the foot of the bed, facing the head of the bed, or at the head of the bed, facing the foot of the bed. I'm going to make sure that we lock the wheels on the wheelchair, and your footrests are folded up or removed from the chair. I'm going to make sure that your bed is locked before getting you up, and if you could sit up on the side of the bed for me. and put on your shoes. Once you lower the bed, so that your feet are flat. You place your robe on you to prevent overexposure, which is going to be sitting up. And we're going to place the gait belt around your waist so that it fits snugly with one flat hand or 4 fingers fitting between under the gait belt, making sure it's tight enough or it's not going to slide in there and absolutely help you up. And the instructions we have here: I need your feet flat on the ground, shoulder width apart, with a light edge support. And I'm going to ask you to place your hands on your bed. On the count of 3, you're going to push up and stand. We're going to pivot and sit into your wheelchair. You're going to make sure that your legs are touching the wheelchair before you sit down, so that your hips are touching the back of the chair, your spine is alongside the back of the chair. Yeah. Any questions? Okay, so I'm going to stand in front of you just to make sure that we have securing your legs, my feet in front of your feet, my knees in front of your knees, and I'm going to bend at my knees and not my waist for proper body mechanics. On the count of 3, we're going to sing. 1, 2, 3. Pivoting over to your chair, putting your back to your legs before you sit down, and go ahead and sit. 1, 2, 3. Going to remove your gait belt and get your feet on the seat rests appropriately. I'm going to place this lap blanket in your lap for comfort, just making sure it's not hanging over your wheels or over draping the wheels. Here's your call bell. Placing everything in full utility. And washing my hands. And then open your privacy curtain. Thank you. Have a nice day.
Okay, so just make sure that those legs are touching the back of the wheelchair before they sit down, and that they put their hands on the handrests to help guide themselves into the wheelchair. Transporting people in the wheelchairs, you can only push one resident at a time. You also are not allowed to pull them backwards down the hallway. They need to be facing the direction that they are going when you're putting them down the hallway. Now, if you are going into an elevator or if you're going over a threshold of a door where there's a big bump, then you can turn them around and pull them backwards over top of that big bump. You don't want to be pushing them forward, hit a big bump, and they topple over out of the wheelchair. So if you're going into an elevator or if you are going over a huge threshold from where different areas of the tile and the carpet meet, then you may need to turn them around and temporarily pull them backwards. If you're pulling them up onto the wheelchair scale, you can turn them around and pull them backwards up onto that ramp with a wheelchair scale. Only pushing your one wheelchair at a time. If you need to transport 2 patients to different places, push one first, then come back for the other. Walking a resident with your gait belt is just like transferring them into the wheelchair, but patients who are ambulating or walking need to be able to bear their own weight. Okay? The residents, even if they're an amputee, they can still bear weight on one leg, and then they use their walker to help them to balance. And then they jump in or hop into the walker when they're pushing it. But they may also have a prosthetic leg that you can put on the other leg, and then they can still ambulate. But they have to be able to bear their own weight in order to ambulate. The residents' feet are flat on the floor. They have to have shoes on before standing. You're standing directly in front of them to help pull them up out of the bed to stabilize them, to make sure their legs don't fall out from underneath them. You're giving them the signal that you want for them to stand up. And then you're not supposed to let go of the gait belt. You're just going to shimmy around to the side, holding onto the gait belt or holding it at the back. Stand to one side of them, slightly behind them. If they have a weak side, you're going to be standing on that weak side. Okay? Encourage them to walk straight, walk erect with their back up, look forward, watch where they're walking. When they're walking, their heels hit first. So taking normal steps with the heel of the foot hitting first and then walking and ambulating. You are not holding up their weight by the gait belt. You are just using the gait belt to guide them.
Come in.
Hello, Mr. Mims. My name is Tanya. I'm going to be your CNA today. It's time to ambulate. The supplies I'm going to need for this are going to be your transfer or gait belt, a robe to help prevent overexposure, and make sure you have some shoes or non-skin footwear. Okay? I'm going to wash my hands, hold your privacy curtain, and assist you to sit on the side of the bed. You can sit on the side of the bed and dangle. Before getting up, we're going to make sure that you have your shoes on. And I'm going to lower the bed to a low position so that your feet are flat on the floor. I'm going to make sure that your bed wheels are locked. And then I'm going to get this robe on you. You put the robe on your backside to prevent overexposure. And we're going to put your transfer or gait belt on around your waist so that it fits snugly and tightly around your waist, where one flat hand or 4 fingers can fit underneath it, so it doesn't slide up and down your body. I'm going to hold my hands in the sweep supination, my palm facing upward on either side and grasp. And before we stand, I need you to put your hands on the bed, and on the count of 3, we're going to stand. Okay? Forward. Put my feet in front of your feet with a wide base of support with our knees shoulder width apart. And 1, 2, 3, stand. You're going to slide behind you and slightly to one side, and we're going to walk 10 feet forward. Walk normal with your feet touching. Turn around. Okay. If you would come back around and get your legs so that they are touching the bed. Get a little bit further here. Feet shoulder width apart. On the count of 3, you're going to sit. 1, 2, 3. I'm going to remove your transfer belt. And remove your gown. All of our supplies are going to go to the soil utility. If you would take off your shoes. And lay back down in your bed. And make sure your bed is in a low position. And here's the call down. If you need anything, call me. Open your privacy curtain, wash your hands, feel complete.
Okay.
Assist the resident to walk the required time and distance. Allow and encourage the resident to rest as needed. Encourage the resident to hold the handrails unless a walker is used. Encourage the resident to stand erect with back straight and head up. Teach the resident to walk normally with the heel of foot touching the floor first. Assist the resident into chair or bed after ambulation. Perform your procedure completion actions.
Okay, so a walker is used with a resident who needs a little bit of help bearing their weight, but they can still bear their weight, they just need a little bit of help or assistance with bearing weight. When you're getting somebody up to the walker, you are not letting them pull up from the chair on the walker. They need to stand up first and then hold on to the grips of the walker. The walker is at waist level. The hand grips of the walker is at their hip or waist level. It's already adjusted for the height of the person, but they need to be standing first, pushing up from the chair, pushing up from the bed, get into your standing position, and then place the walker in front of them and hold on to the hand grips of the walker. They're going to push the walker forward about 6 to 8 inches and then step into the walker. And if the patient just needs to have help with balance, then they're just going to use their cane. They hold their cane on their strong side. But again, they don't use their cane to pull themselves out of a chair. They're already in a standing position before you hand them their cane, and then they can start using it. Their canes and their walkers and their wheelchairs need to be stored close to the bed where they can reach them and where they can get to them in an emergency.